Greetings, everyone. Good morning, good afternoon, or good evening, wherever you are. And thanks, first of all, for joining us today for this Children and AIDS Learning Collaborative webinar, where we will bring a summary of the newest science and the newest programmatic learning on children, adolescents, pregnant women, and HIV that was presented at the International AIDS Conference and at the HIV Pediatrics workshop, which both took place in Montreal between the 27th of July and the 2nd of August. My name is Rika Kierkegaard. I manage UNICEF's Learning Collaborative on Children and AIDS, and I will be your host today for this scientific webinar presented to you all by Dr. Lynne Mofenson. Dr. Mofenson is currently working as technical advisor to the research program at ECPAF. She was at the National Institutes of Health from 1989 until her retirement, where she was responsible for program planning and the development and scientific direction of research studies and clinical trials in domestic and international pediatric, adolescent, and maternal HIV infection. So we're very pleased to have Dr. Mofenson with us again today. And we have now for quite a few years convened these webinars together, but this year we'll be doing it a little bit differently and bring in programmatic experts as well. We'll reflect on some of the implications for practice of the newest developments. So we have Laurie Gulaid, UNICEF's regional HIV advisor for Eastern and Southern Africa. We'll discuss the implications for prevention of mother-to-child transmission and for pediatric HIV programs. And then we have Shirley Mark Prabhu, who is health specialist with UNICEF's regional office in the Middle East and North Africa, who will be discussing the implications for programming for adolescents and for PrEP as well. So we have over 90 minutes for the webinar today. The presentation will last just over an hour and will then be followed by Q&A, which will be moderated by Shafiq Isaji, our senior HIV advisor here at UNICEF headquarters. Before we move on to the presentation, I would like to mention a few practicalities. First of all, please use the chat box for any comments or concerns. Send a message if you have any technical issues or if you have any general comments. And second of all, if you have a question to any of our three speakers, you can send them at any time using the Q&A box, and we'll then get back to your question after the presentation. Then a final note is that the webinar is being recorded, and as always, we'll be sharing the recording and the PowerPoint, as well as a longer slide set. After the meeting, we'll share it on childrenandaids.org, where you can also find recordings of previous webinars, and you can sign up for the Children and AIDS Learning Collaborative mailing list, not to miss out on future webinars. So without further ado, over to you, Lynne.
Okay, thank you, Ricky. You can hear me, right?
Yes.
Yes, okay. So let's move on and talk about the abstracts. So I want to first start with an update on epidemiology of pediatric HIV that was given at the International Pediatric Workshop by Mary Mahey. So starting out with ART coverage in pregnant women. 81% of pregnant women with HIV received ART in 2021. But if you look at the purple line, you'll see that there has really been no meaningful increase in pregnant women coverage since 2014. And there are significant regional differences. West and Central African coverage was only 60% in 2021. And 43% of all pregnant women who are not receiving treatment are from this region. Now, this slide looks at new pediatric infections, and that is the blue line. There were 160,000 new pediatric infections estimated in 2021. And if you look at the blue underneath, you can see that there's been minimal change in new infections since 2015, either no change or only a 10,000 decline a year. So if we assume that there'll be only 10,000 decline a year, it's going to take us another 14 years till 2035 to meet our 2020 target of 20,000 new infections. This slide looks at the causes of new child infections. So 22% of new child infections in 2021 were due to incident infection during pregnancy. A full 48% where the mother did not receive treatment during pregnancy or breastfeeding. 22% was the mother didn't continue her treatment during pregnant or breastfeeding. And only 8% was that the mother was on treatment but not virally suppressed. So globally, 75,000 new child infections still occur because pregnant women are not diagnosed and started on treatment. And there are regional and country differences, and almost half of those not receiving treatment, as we just talked about, are from West and Central Africa. And over half of the incident infections that lead to vertical transmission are in East and Southern Africa. This slide looks at early infant diagnosis, and in gray, you see global data, and globally 62% of infants had early infant diagnostic testing by 8 weeks in 2021, a slight decrease from 63% in 2020. The orange line is from West and Central Africa, and here EID is only 25%, having actually decreased between 2019 and 2020. And the blue line is EID in East and Southern Africa, which was 71%, but even this was a slight decrease from 74% in 2020. This shows you ART coverage in children compared to adults. ART coverage in children remains at 52%, didn't change between 2020 and 21, and is consistently lower than that in adults, which actually increased from 74% to 76% in 2021. Now, 60% of the children not on treatment are aged 5 to 14 years. And this tells us that early infant diagnosis is not enough, and there's a need for home testing or self-testing to identify older children living with HIV. And we'll talk more about that in a bit. And then finally, despite new, more potent antiretroviral availability, decline in deaths among young people has slowed. And on the left side, you see AIDS-related deaths in adults over 15 years, with females being in the lighter green and males being the darker green. And you can see AIDS-related mortality in adults continues to decrease and is higher in males than females. But on the right, you see AIDS-related mortality in young people has had minimal decline since 2013. And here it's higher in females than males. So kind of depressing information related to epidemiology, perhaps still COVID related. So let's talk now about pediatric treatment optimization. So the first abstract comes from Baylor. It's a retrospective review from 7 sites in 6 countries on almost 12,000 children enrolled in care and who were prescribed dolutegravir treatment. Most of these children were over 10 years, as you can see. Most were treatment experienced, only 21% were naive, so the majority were switching. And importantly, 95% were virally suppressed at baseline before switching to dolutegravir. The mean follow-up on dolutegravir was 22 months, and they had viral load results out to 60 months, but the sample size after 24 months is very limited, so I'm only going to show you results to 24 months. And these were very good results. This shows you viral load suppression over time, over 90% from 6 months to 24 months, and they had no real difference in suppression by sex, age group, or NRTI backbone. Now, this looks at viral suppression on dolutegravir where there's been only a single drug substitution. So a substitution from an NRTI or a PI to dolutegravir without changing the backbone in 210 children who were not suppressed at baseline. And if you first look at all children, you can see that about 80% suppressed after not being suppressed after switch to dolutegravir, and this was maintained over time. And it didn't matter whether they were on abacavir, AZT, or tenofovir-based drugs when they switched. So limited numbers, but suppression of about 80% maintained over time with no difference by NRTI backbone. This also comes from Baylor and is now focused on about 1,500 children enrolled in care and who changed from protease inhibitor to dolutegravir-based treatment. Median age was 14 years. The kids had been on PIs for almost 10 years, most of them on lopinavir or ritonavir, and 88.9% were suppressed on the protease inhibitor. Follow-up on dolutegravir was 212 days, and post-dolutegravir viral suppression was 89.8%, so that there was really no difference. 118 youth were unsuppressed on protease inhibitors, and 68% of these suppressed after a switch to dolutegravir. And when they looked at viral load suppression by sex, female versus male, or by age, you can see viral suppression was lower for both PI and dolutegravir treatment in females and in adolescents 15 to 19. So switch from PI to dolutegravir treatment was effective at maintaining and achieving viral suppression, and that continued attention to support females and older adolescents is needed. This looked at transition to dolutegravir-based treatment in West Africa through the Pediatric IDEA West African cohort, about 2,800 youth and children on treatment with one or more visits since 2019 in 7 clinics. So 43% had transitioned to dolutegravir by June 30th, 2021. Now we're looking at the relative risk for dolutegravir transition. On the left, you see sex with males being in blue, females being in orange, and you can see that males were more likely to transition to dolutegravir than were females. The one on the right shows you access to viral load, with viral load being less than 500 in blue, greater than 500 in orange, and no viral load in gray. And you can see that children who had no viral load were less likely to transition. And so factors associated with dolutegravir transition included male sex, no viral load access, older age, and being on second line. So there was relatively slow transition to dolutegravir. Access associated with male sex, this may be pregnancy concerns potentially in older adolescent girls. Access to viral load testing, age greater than 5 years, this is likely due to the dolutegravir formulation availability being low for children under 5 and being on second line treatment. This is a study of uptake of raltegravir granules in newborns in Zimbabwe during the COVID-19 pandemic, coming from UNICEF and EGPATH. So raltegravir granules were introduced in 14 health facilities with the capacity for point-of-care HIV birth testing in Zimbabwe, and healthcare workers were trained on raltegravir use and caregiver counseling, and the study population included all infants exposed to HIV born at the project sites over a 1-year time period. So if you first look at the graphs on the left in blue, you see the point of care testing cascade. Of the children exposed to HIV, 45% had a point of care birth test result, and 59 or 1.9% were diagnosed with HIV. And in orange, you see the ART initiation in the raltegravir cascade. So of those 59 diagnosed with HIV, 78% received treatment, and 58% were started on raltegravir. And the little circle here shows you the different regimens that the newborns were started on. And I just want to point out that 13 children, despite being infected, were not initiated on treatment, with a significant proportion of that being because a drug was out of stock. So of these 59% of infants who started on raltegravir, they started pretty early at 4 days of age. At day 28, when a switch to non-raltegravir treatment is recommended, data were available on 85% and 78% switched as recommended. Weight check for dosing, however, did not appear to be done very frequently. So there was lower than expected birth testing uptake and raltegravir usage. And this was likely due to inconsistent supply chain, both for the point of care testing as well as raltegravir, and importantly, pediatric AZT3TC, a shortage of trained healthcare workers because there were strikes and high staff turnover, and that data points were not recorded well. So need to address health system gaps for supply chain, staffing issues, including training, retention, mentorship, and supervision, and the ability to track newborns and maintain documentation of weight and raltegravir dosing. This comes from USAID and looked at viral load testing in over 48,000 children under age 5 years in 2019, 20, and 21 in 11 countries that were supported by USAID. So the first thing you'll see is coverage is lower in children aged less than 5 than adults in all 3 years. So in blue, you see children less than 5, and in red, you see adults over 15. And you can see in all 3 years, there was a significant lower viral load coverage in young children. And then if you look by age, you see that coverage was lower in children aged less than 5 years than all other age groups in these countries. Now, coverage by country and age showed significant variation. So for example, if you look in the green box in Uganda, 90% of adults had viral load testing and 88% of kids, so pretty good. But if you look at the red boxes, in Zimbabwe, it was 57% for adults, so pretty low, but even lower, 38% for kids. I'm looking at the most recent year now. And in Kenya, we had both adults and children had very low coverage, 35% in both. And they identified a number of barriers in these countries, including patient factors, health facility performance challenges, specimen transport problems, stockouts and shortages, lab challenges, and information system issues. So they went on to talk about examples of what countries did to facilitate viral load testing in children. And the first thing they talked about was community viral load sample collection helps improve access. So COVID led to actually the rapid expansion of community and home-based services, and viral load sample collection was done in some countries via home visits or visits to community locations. The second was using OVC case managers and other community workers to help reduce patient barriers and improve access. And about 70% of children under 5 on treatment in these countries were enrolled in OVC programs. Next was improving family-centered differentiated service delivery and multi-month dispensing models to improve access and convenience. Simplification of pediatric sample collections with better phlebotomy supplies and or the use of dried blood spots was another technique used. And then finally, using point of care testing to reduce turnaround time for test results. So despite the increased risk of morbidity and mortality in the youngest children, these children were substantially less likely than adults to receive viral load testing. And several promising strategies were being tested to improve viral load testing among these young children. And tracking the speed, coverage, and fidelity of the scale-up of these interventions is going to be critical to assess our success and impact. So moving to a couple of abstracts that talked about pediatric HIV disease progression in the treatment era. The first is a study from the Earth EpiCal cohort of 212 infants who were all started on treatment at age under 3 months in Mozambique, Mali, and South Africa, and they're being followed through age 4 years. And you can see that the median time they started on treatment was 34 days, most on lopinavir, ritonavir, and unfortunately suboptimal adherence in 56%. So 23 patients or 11% died. They died at a median of 2.5 months, and 74% of the deaths occurred in the first 6 months. The probability of death at 1 year was 11%, at two years was 12%. So that's despite starting on treatment early. This looks at the reasons for death. So AIDS-related mortality was in 52%, and you can see the individual causes underneath. And then non-AIDS related mortality in 48%. So they looked at what was causing the excess of mortality compared to baseline mortality in each country. And you can see it varies, but generally AIDS-related mortality was the reason for excess. And then this looks at what was related to mortality. Longer time on treatment was protective. And if you were on the nevirapine-based regimen, there was a higher risk of mortality. Baseline viral load was more associated with death from non-AIDS causes, and CD4 was related with both AIDS-related causes and other causes. So if you had a low CD4, you were at risk for both AIDS and non-AIDS death. This looks at mortality in children and youth who are lost to follow-up in Southern Africa using linkage and tracing. This was an interesting study. They used data from tracing and linkage studies in Southern Africa to correct for mortality and loss to follow-up in children receiving treatment. And you can see the definitions of loss to follow-up are below. So the tracing cohort was done in 5 countries. All children aged 0 to 24 years who started treatment at IDEA sites. The linkage cohort was in South Africa, the Western Cape, using electronic medical records. So the tracing cohort was done on a stratified random sample of clinical participants. 70% were able to be traced, and 68% had tracing successful in terms of determining vital status. In the linkage cohort, they used unique patient IDs to assess if the patient lost have any linkage to another site. Almost 1,500 were recorded as lost to follow-up. 72% could be linked, and 85% of these had vital status ascertained. So this looks at tracing cohort patient characteristics by sex, male in green and female in orange, by year of treatment start, by duration on treatment, and age at last visit. And the factors in the multivariate analysis that were associated with successful tracing in the tracing cohort was longer duration on treatment, country, and the year that treatment was started. And when they looked and compared mortality without accounting for mortality with the loss to follow-up in the naive group, that's blue, and then they looked at the corrected estimates once they did tracing, you can see that there was a significant difference with the cumulative mortality being much higher when they accounted for mortality in the loss to follow-up group. And this is the linkage patient characteristics, very similar to above. And here the factors associated with successful linkage was sex and site, and basically found the same data, that if you correct for loss to follow-up mortality and loss to follow-up, the actual mortality is significantly higher. So mortality was 2 to 2.5 times higher with these additional outcomes in those lost to follow-up. And the data from linkage and tracing was very similar. And this suggests that program level mortality in HIV positive children is significantly underestimated if additional ascertainment to account for the mortality and loss to follow-up is not accounted for. Now we're going to move to HIV testing and case finding. And the first study comes from Uganda, and they analyzed HIV testing data in about 3,300 PEPFAR supported sites in Uganda. And they did a pediatric HIV risk assessment tool, which you see on the right, that included questions on sick in the last 6 months, recurring skin problems, not growing well, ever had TB, lost weight, and maternal HIV positive status. And they looked at before this risk assessment tool was put in place in 2019, and then after that risk assessment tool was put in place along with expanded index testing to explore changes in testing in children. And they looked at the number needed to test to identify one new child with HIV. So if we look at all testing modalities, in blue, you see pediatric testing. You see pediatric testing decreased by about 13%. HIV diagnosis is in green. HIV diagnosis actually increased by 1.8%. And the number needed to treat, the little yellow dot, decreased from 55 to 47. For outpatient testing, pediatric testing decreased by 8%. HIV diagnosis increased by almost 50%, and the number needed to test decreased from 54 to 40%. And then when they looked at index testing in particular, which they wanted to increase, they had an increase by nearly 90% in index testing for children, with an increase in HIV diagnosis of 42%. The number needed to test increased, but the number of HIV diagnoses also increased. So the use of this validated risk assessment tool and increased index testing can increase pediatric testing and case identification among children with the highest risk, especially in high volume and or low prevalence settings. And the use of the risk assessment tool resulted in a significant reduction in the number needed to test, making outpatient testing slightly more efficient than pediatric index testing. This came from an evaluation of an HIV risk assessment tool, the Zimbabwe HIV risk assessment tool that you see on the right. The questions were, have the child ever been admitted to the hospital, sick in the last 3 months, recurring skin problems, any biologic parent or sibling died. And they evaluated it in Uganda with a 1.6% HIV prevalence, Tanzania 0.4% prevalence, and Malawi 0.8% prevalence. And then they also looked at alternative tools selected through machine learning approaches. So you see first that sensitivity and specificity differed across countries, and the number needed to test to identify one new HIV-infected child also differed between countries. In green, you have the number needed to test, and in gray, you have the prevalence. So as the prevalence goes up, the number needed to test goes down. They found including maternal HIV status significantly increased sensitivity. So if you ask, in addition to these risk questions about maternal status, that increases sensitivity and pickup. They selected an optimal tool based on 3 questions: growth problems, biologic parent or sibling HIV positive, and recurring skin problems. And this alternative tool increased sensitivity and specificity and decreased the number needed to test, but it did have poor discrimination for older adolescents. So variable sensitivity of the tool based on HIV prevalence in the country, meaning that different tools may work better in different countries. And it was more beneficial in children than in adolescents, and the performance was better in outpatient than community settings. This was an interesting one. This looked at the acceptability, feasibility, and effectiveness of implementing caregiver-assisted oral fluid-based HIV screening for children as part of index testing for HIV-positive adults in a cluster sampling design in 32 facilities in Uganda and 15 facilities in Zambia. So here we have on the right the inclusion criteria. So you have a positive indexed a parent or caregiver who has children who would be eligible for testing, and they were offered 3 different options: take an oral test home to test your kid at home, bring your child to the facility for a blood-based test, or a community healthcare worker will come to your home and test your child with a blood-based test. So Acceptability, 97% of eligible index parents and caregivers accepted the oral test kits. Of the kits sent home, 98% of the children were tested and results returned to the facility. Feasibility, 1.6% of the children had a reactive oral test result. 98% of these children completed their confirmatory blood-based testing at the facility, and this decreased the need for facility-based testing by 98%. And effectiveness, out of the children who had a reactive oral test, 37% had confirmed HIV positivity. 98% of these children started on ART on the same day. So there is a potential new acceptable and feasible addition to HIV testing modality toolkit for identification of HIV positive children. And this ability to provide parents with the oral test to test their kid at home can help decongest facilities. This was a study in Nigeria that looked at different HIV self-testing models. So one model was facility-based with primary and secondary distribution via various healthcare services. They had a key population, one-stop shop type distribution of self-tests, community self-tests, and then self-tests available in the pharmacy. Most of these tests that were distributed went to the facility and community. So this looks at HIV self-testing by model, age, and sex. And so we have males in green, females in orange. The younger children are in the little red box and adolescents in the blue box. So in facility-based testing, older men accessed self-testing kits more than women. And you can see that you did identify children and adolescents here as well. In the key population testing, more women, probably sex workers, were reached than men. And this is all in older individuals. Community testing did identify some children and adolescents, but not as much as facility. And community testing reached more men than women from age 20 onward. And in the pharmacy, these are mostly older people, and the men access the kits more than women. So this looks at the results. In green, you see distributed. In orange, you see reported, and the light green shows you reactive. So of the test kits that were distributed, 2.5% overall were reactive, and the one-stop shop for the key population had the highest yield, 4.9%, followed by facility-based testing, 3%. This then looks at confirmatory testing, so you have HIV reactive oral test in green, attended confirmatory testing in orange, confirmed HIV positive in light green, and then initiated treatment in blue. And you can see 96% attended confirmatory testing, 98% of these were confirmed positive, 99% initiated treatment, with the lowest amount being in the pharmacy group. So self-testing distribution was acceptable and feasible across diverse settings and populations and age groups in Nigeria, and did manage to reach high-risk persons not tested previously. Positivity rate was optimized by using one-stop shop serving key populations. They achieved a high result return, enabling support and linkage based on the result, with the lowest rates of confirmatory testing in the pharmacy distribution. So I'm not sure whether it's Laurie or Shirley, but you want to talk about implications for programming.
It's me, Lynn, and hello,
Okay.
everybody. And thanks so much, Lynn, for such a clear presentation of such rich information. I'm greeting you all from very sunny Nairobi. So I'm sure our heads are popping with all the implications for programming, but let us just highlight a few. I think this is the stronger and stronger evidence that we've seen that early ART with DTG as a first line is the way to go for children, and it must be scaled up. I think it's great to see what governments and their partners are already doing, and we just want to keep that trend going. This is because, again, the field experience confirms that DTG is working well, even for those kids who are switching from protease inhibitors as their first line, and even for infants who are treated as early as 3 months. And of course, this is so important to us given mortality rates in the first 6 months. DTG levels also do not seem to be affected by food in children as they are in adults. And just a special note to say that we really see out of this evidence that differentiated service delivery is still called for, especially among older adolescents, 15 to 19. We also see clearly that viral load testing of children needs to improve. It's less accessible, especially to those under 5. And what's interesting to note is that the switch to DTG may provide an opportunity to increase access to viral load for children, and we've seen this in some settings. There are also other promising strategies and modalities for testing, including viral load test collection in communities and point of care technology, which brings us to the broader issue of multimodal approaches to testing. I mean, really, it's about the whole diagnostics system. And we're seeing in this evidence that supported oral HIV tests are widely accepted and have been used as home-based tests for index testing to identify children. I mean, the numbers that Lynne shared were really impressive about caregivers who took the tests home and came back with the results. And lastly, on just for this quick slide, that these risk assessment tools really seem to be working to increase case finding and reduce cost. And we really encourage countries that are using these to continue and document and share their experiences. Thanks, and back to you, Lynne.
Okay. So moving to pregnancy. So the first one I want to talk about was a meta-analysis of over 1,000 pregnancy outcomes from several clinical trials, Dolphin 1, Dolphin 2, the Vested trial, and pregnancies that occurred in the Advance and NAMCEL trials. So this looked at stillbirths, neonatal deaths, transmission, and all of these put together. And in blue, you see dolutegravir. In green, you see efavirenz. And basically, there were no significant differences overall in risk of stillbirth neonatal death or MTCT rates between dolutegravir and efavirenz arms. There were individual differences between outcomes in the trials. So Dolphin 2 and Vested had different results, but they're smaller sample size. There were 5 cases of transmission in the dolutegravir group. The vast majority of these were very early, and one was with only 3-week duration of dolutegravir. So all of these occurred in utero. And there was 1 case of breastfeeding transmission with efavirenz. This was a study from Kenya that looked at almost 200 women receiving dolutegravir peri-conception, and they matched these to almost 400 women receiving efavirenz peri-conception. And then they looked at adverse pregnancy outcomes, any outcome preterm, small for gestational age and stillbirth. And dolutegravir is in gray, efavirenz is in black. And the first thing you see is that adverse outcomes were common in both dolutegravir and efavirenz, but there were no significant differences in adverse pregnancy outcome between peri-conception, dolutegravir versus efavirenz, and no neural tubes in either neural tube defects in either group. This comes from the European Dolomite study, and they were looking at dolutegravir exposed pregnancies. 92 of these were, of 138 dolutegravir exposed pregnancies, 92 were exposed in the first trimester, with 77 of these being preconception or exposures. There were 16 miscarriages and abortions, 2 stillbirths. All of these occurred in the first trimester exposures, 131 live births. And the basic message here was there was no significant difference in low birth weight, very low birth weight preterm or very preterm by trimester. And 5 birth defects seen, no neural tube defects, and no significant difference between birth defects in the first versus second or third trimester. An update on the Tisamo Botswana study was provided, which I'm sure everyone remembers as a surface birth outcomes surveillance at sentinel sites in Botswana. And you can see here the numbers exposed to dolutegravir from conception are now almost 9,500. 23,000 non-dolutegravir from conception, et cetera. So there were 156 neural tube defects identified. And you can see the results here, 0.11% now with dolutegravir from conception, which is now exactly the same as non-dolutegravir from conception, 0.11, 0.08 for efavirenz from conception, 0.06 dolutegravir during pregnancy, 0.07 women without HIV. So then when you look at the prevalence difference by treatment and HIV exposure categories, you can see now that the prevalence difference is non-significant when you compare dolutegravir at conception to any of the other categories, and that the prevalence of neural tube defects has now declined. And I think this picture shows it the best, which looks at the trends over time. In red, you see dolutegravir preconception, green is non-dolutegravir preconception, blue is efavirenz preconception, orange is dolutegravir start during pregnancy, and purple is HIV uninfected. And everything is basically a straight line except for dolutegravir preconception, where they started out with only about 500 exposures. And as the number of exposures increased, the prevalence decreased, and now we don't see a significant difference. This is a study in Malawi that is modeled on the Tisambo study. They had implemented data collection for birth defect surveillance at high volume sites. Now they are presenting data, but it is not analyzed yet by specific maternal regimen or timing. There were almost 174,000 births, 10% were to HIV positive women, the vast majority on treatment. And this looks at the prevalence of preterm birth and the prevalence of low birth weight, with HIV negative women in blue, positive women on treatment in orange, positive women not on treatment light green, very small numbers. So you can see the rate of preterm delivery and low birth weight was actually highest among the women not on treatment, demonstrating the importance of testing and early treatment. And the rates of preterm delivery and low birth weight in women on treatment were slightly higher than HIV negative women despite being on treatment. And this looks at the prevalence of birth defects, again, negative blue, HIV positive on treatment in orange. There were 688 defects, most common you can see here. And there was a non-significant increase in defects in HIV positive women on treatment when compared to HIV negative women. NTD prevalence here was 0.08 in women on treatment, not that dissimilar from what was found in the Tisambo study. This looks at prenatal PrEP and looks at long-term outcome for growth and neurodevelopment in infants who were exposed to PrEP, following them through 24 to 36 months. So this was from a cluster randomized trial, and they then had an observational cohort that followed the mother-child pairs until 60 months post-birth. This just shows you the gestational age at PrEP start, 27 weeks, duration of PrEP exposure during pregnancy, almost 2.5 months. And then they compared growth and neurodevelopment among infants who had any PrEP exposure during pregnancy compared to those who had no PrEP exposure during pregnancy. And the only difference here between the groups was that the partner was known to be living with HIV in those with any compared to none. And that's probably because the mothers who were most at risk for HIV were taking their PrEP. So this looks at child growth indicators, 24 and 30 months. And they compared any PrEP exposure to no PrEP exposure. And they also looked at the percent underweight or stunting. And the major message here is there were no difference between any and none exposure. And again, this is child neurodevelopment. I'm not going to go in detail, but just to note that there was no significant difference in neurodevelopment between those with any versus no PrEP exposure. So this is very reassuring data on the safety of PrEP use in pregnancy. This comes from Central Africa IDEA sites in Rwanda, and they looked at birth outcomes in women who gave birth at these sites. And this shows you pregnancy outcome by HIV status, with women with HIV in orange and uninfected women in blue. And you can see stillbirth, preterm, and low birth weight were higher in HIV positive women. And when they did a multivariate analysis, the things associated with low birth weight were HIV positivity despite being on treatment, higher maternal weight at admission, and being a prima gravida. So even in the age of universal treatment, HIV positive women remained more likely to have low birth weight babies. And then I'm going to talk a little bit about PMTCT cascade issues. There was a very nice presentation from the CPAC group looking at the cost effectiveness of broadly neutralizing antibodies. So a strategy is viewed as cost effective if it was cost savings or had incremental benefit less than 50% of the country's annual GDP. So the standard of care strategy is that infants with known HIV exposure are offered one of the WHO oral antiretroviral prophylaxis strategies. And then they modeled offering BNABs to one of 3 target populations. In green, BNABs were only given to high-risk infants with known exposure. In blue, BNABs were given to all infants with known HIV exposure, and purple was BNABs given to all infants regardless of their HIV exposure. And then they looked at 3 different dosing approaches: a single dose, 2 doses at birth in 3 months, or extended dosing every 3 months while breastfeeding. And this just shows you the key parameter assumptions that they used in the analysis. And when you take a look at the slides, you can look at this in more detail. So this looked at cost effectiveness. So just by country, Ivory Coast, Zimbabwe, and South Africa. The white X shows you the assumption, 70% efficacy, $20 a dose. And then they looked at broad neutralizing antibody efficacy ranging from 10 to 100%, and cost per dose ranging from $5 to $100 per dose. The green is the high risk only, the blue is all HIV exposed, and the purple is all kids regardless of HIV exposure. So if you look at the Ivory Coast, you can see that giving broadly neutralizing antibodies to all HIV exposed infants for the extended period of breastfeeding was the most cost effective, regardless of efficacy and almost regardless of cost. In Zimbabwe, again, giving to all HIV exposed infants for the extended period was the best across most of these variations. Whereas in South Africa, giving HIV regardless of exposure appeared to be best. This looks at dual HIV syphilis elimination in Nigeria. So globally, there are over 1 million cases of syphilis in pregnant women. It's the 2nd leading infectious cause of stillbirth globally. And despite this, there is a significant disparity in national coverage. And this graph looks at coverage between syphilis testing in blue and HIV testing in red by country, and focus on Nigeria. You can see there's a 51% disparity in HIV versus syphilis testing in pregnant women in Nigeria. So CHI worked with the folks in Nigeria to increase dual HIV syphilis testing. 45,000 women attended the pilot sites. Syphilis positivity was 0.2%. Almost all of the women who with positive syphilis positivity were treated, and 42% of their partners were treated. At the global level, CHI facilitated marketing and made sure that the supply was there. And then in Nigeria, they made a national policy change after that HIV and syphilis testing should be offered to all pregnant women seeking antenatal care. And interestingly enough, this increased the number of pregnant women tested for HIV from 67% to 95% by 2022. and they plan to increase testing for syphilis to 60% by 2026. And this shows you recent WHO data showing that 33% of reported countries have reported adopting dual HIV syphilis testing. And I just wanted to point out that in Africa, 72% of the countries have adopted dual testing. This is a randomized trial in rural health facilities, which enrolled women who had given birth in the prior 6 months and their male co-partners. And it was a multi-component community-based intervention that included women's empowerment groups, men's facilitated dialogue sessions and family charters, and community and facility work with the healthcare center committee and nurse. And they did before and after implementation surveys to measure the impact on maternal mental health using the Edinburgh Postnatal Depression Score. And they looked at male engagement. So they found a reduction in the depression score, meaning decreased depression in both intervention and control arms, but the decline in depression was 34% greater in the intervention compared to the control arm. And characteristics associated with depression, including maternal HIV positive status and intimate partner violence. They also found in the intervention group improvements in timely ANC, couple HIV testing in pregnancy, and timely postnatal care for the mother and the baby. And they also found a significant impact on submeasures of, in the men, of relationship dynamics, men's gender attitudes, and support for their women. So this low intensity intervention positively impacted maternal mental health, ANC cascade, and improved couples relationships, and also points out that women living with HIV and survivors of intimate partner violence need targeted mental health support. This study looked at the impact of maternal treatment status at time of entry into ANC on the ability to identify those who are going to have gaps in care later. So they looked at differences in HIV care gaps between delivery and 24 months postpartum based on maternal history at the time of pregnancy. So this looks at changing percentages of women on treatment in blue, restarting treatment in orange, and newly starting ART in green by year of delivery. And as one might expect, the percentage of women on treatment has increased over time. The percentage of women starting on during pregnancy decreased over time, but also the number who had been on treatment stopped and then were restarting treatment increased as well. And this looks at the cumulative incidence then of postpartum gaps in care based on their history of treatment at the time of pregnancy. So at 1 year postpartum, 16%, at 2 years postpartum, 31% had a gap in care. And you can see here in blue, which is the women who were on treatment when they came into care, had the lowest rate of gaps in care, followed by those who had started during pregnancy. But importantly, this orange group, the group who had restarted treatment, were really the groups that had the incidence of postpartum gaps in care. So they noted that increasing numbers of women are presenting for ANC on ART. Women who are newly starting on treatment in pregnancy have an increased risk over them of having a postpartum gap in care. And this small but growing group of women who are entering care, restarting treatment in pregnancy, have the greatest risk of having a postpartum gap. And so assessing our treatment history during ANC can facilitate support interventions to optimize postpartum retention and care. Going to try to move more quickly. This is HIV-exposed uninfected infants. These are data from Montreal, and what they did was they looked at the incidence of hospitalization and chronic disease in HIV-exposed uninfected children compared to matched HIV-unexposed uninfected children. So the HIV-exposed uninfected children is in blue. The children who are not HIV exposed are in red. And you can see there is a 1.4-fold increase in hospitalization for children who were HIV exposed but uninfected. Once they adjusted for gestational age and this excluding prolonged birth hospitalizations, the difference still was there. And then they looked at chronic conditions and found that chronic conditions, including congenital abnormalities, but importantly, neuropsychiatric disorders, were more common in the children who were HIV exposed, even though they were uninfected. And you can see this includes a variety of different types of neuropsychiatric disorders. This comes from the same group and was a retrospective study looking at congenital CMV. The prevalence in the general population is 0.5%. You can see here, out of over 1,000 mother-infant pairs, there were 40 infants with HIV infection. Two of the 6 that they had samples on had congenital CMV, 33%. And in the children who were HIV exposed but uninfected, 1.5% had congenital CMV. Those who had congenital CMV were more likely low birth weight and preterm. Also more likely to have detectable maternal viral load at delivery and a low CD4 count. So while HIV-infected infants had the highest risk of congenital CMV, HIV-exposed uninfected infants had a 3-fold increased risk of congenital CMV compared to the general population. Highest risk among low birth weight or mothers with detectable RNA or low CD4. So they suggested that all HIV should be tested for congenital CMV at birth. And Shirley or Laura?
Back to me, Lynn, and I'll try to be really brief. That was so rich, and particularly the last slide, so many implications could come out of that. But let's just say that DTG should be offered to all women, including of childbearing age. And we see that there was, in this research, no significant difference in adverse birth outcomes for women on dolutegravir versus efavirenz at conception. And also really continued strong evidence on more rapid and better viral suppression, which clearly benefits both the mother and our efforts to eliminate vertical transmission. In terms of vertical transmission, we see that PrEP is safe in pregnancy, but we really need to consider again the differentiated service delivery models. The small and growing information on PrEP for adolescent and young mothers gives us some ideas of how to tailor services for that particular at-risk population. There's also, just like for kids, it's promising to look at community maternal viral load test collection and point-of-care test collection. The broadly neutralizing antibodies research gives us some philosophical thought about our programs in terms of always being adaptable to new innovations. You know, we think we have a really great toolbox now, but it is going to continue to get better. And then how important the contextual factors are. We didn't put a bullet point, but I just do want to stress that looking at ART history for women is another just critical input for trying to assess risk and tailor our care for women at higher risk. And for the children living with HIV who are exposed and uninfected, I think the challenge before us is how do we make sure these children are integrated in other programs for kids who are vulnerable or at higher risk and can receive early childhood development, extra health care, and nurturing care framework type interventions. Back to you, Lynn.
Thanks. Okay, moving on to talk more about PrEP. This looked at the effect of a 6-month PrEP dispensing as opposed to 3-month PrEP dispensing on PrEP continuation at 12 months in Kenya. So they had a randomized trial where standard of care was 3-month PrEP and clinic-based testing, 6-month PrEP and oral HIV self-testing, or 6-month PrEP and blood-based HIV self-testing. And they looked at a variety of different outcomes, and you can see here more details about the difference between the regimens. And what they really compared was standard of care to 6-month PrEP with self-testing. And here were the endpoints. So this looks at the risk difference between HIV self-testing and standard of care. And on the bottom, you can see the percentages looking at tested for HIV, refilled PrEP, and adherent to PrEP. And at 12 months, the 6-month PrEP dispensing with interim HIV self-testing was non-inferior when compared with standard of care PrEP dispensing at 12 months. Simplified PrEP delivery, and among single women, which is on the right here, it actually increased PrEP adherence, as you can see. So HIV self-testing should be considered to support PrEP continuation, and that you can give 6 months without resulting in a loss of the patients in terms of PrEP. This looked at combination adherence support during pregnancy. So this was a randomized trial of adherence support. So in the intervention group, they had PrEP screening, initiation, adherence, counseling, regular HIV testing, plus patient-centered counseling and an adherence supporter. So this looks at adherence at 3 and 6 months according to tenofovir drug level scores. And I would just say in dark green, you have people who are taking the doses daily, and in lighter green, 4 to 5 doses per week. And that's really what you need to see. And you can see that at month 3 and at month 6, there's really not any difference between the intervention and control. And then they looked at clinical outcomes, retained in care, having good PrEP levels, et cetera, and none of these were significant either. So they found oral PrEP adherence was consistently low, even in this trial setting. And unfortunately, the combination adherence support didn't increase retention or adherence. And it raises the question about whether injectable PrEP might result in improved retention adherence. This was a study that looked at SMS messaging and a WhatsApp support group. So they had HIV negative adolescent girls and women. They were randomized to SMS testing and standard of care counseling, or WhatsApp support groups and standard of care counseling, with secondary randomization in those non-responders as shown here. An endpoint was tenofovir levels that were adequate. So looking at PrEP continuation and adherence, you can see that retained at month 2 was 78%, on PrEP at month 2 was 94%, adherent at month 2 was 62%. Here we go. For the primary interventions, as well as the secondary interventions, really there was no significant difference in tenofovir levels. And then this tried to look at whether SMS or WhatsApp with counseling for non-responders or drug level feedback made a difference, with the major message that nothing really made a difference. So no significant differences between intervention or dynamic treatment strategies had a similar impact on adherence. So individual level interventions may be insufficient to overcome structural barriers. And again, it raises the question of whether long-acting formulations may have promise. This was the HPTN 084 updated results. As you all know, cabotegravir was, injectable cabotegravir was significantly better than oral tenofovir FTC. The blinded trial stopped in November 2020, but patients continued on the randomized protocol pending an amendment for open label. So they're now reporting on HIV infections during the 12-month period following the unblinding. So here you see the blinded period, and here you see the combined blinded and unblinded period. 3 additional CAB group infections were identified. All were associated with poor or absent product use, and no on-injection breakthrough infections occurred. And you can see that this is 89% effective. 80% of the grade 2 events were unrelated to study products. There was no significant problem with cabotegravir. They also noted that pregnancy incidence actually increased during the unblinded period, confirming the importance of evaluating CAB safety and PK in pregnancy. So CAB continues to be superior to oral tenofovir FTC in preventing infections in women with no new safety concerns. This was rather a complicated study, and I'll just give you the end message here. So it was modeling the impact and cost effectiveness of CAB-LA versus oral PrEP over a 20-year time period in South Africa using a specific model. And they used two different coverage scenarios, medium coverage and high coverage. And then for CAB, two different duration scenarios, a minimum duration, 12 months, or a maximum duration. So what you see here in black is baseline, the blue is CAB, the maximum duration, the orange is CAB minimum duration, and and then the green is oral PrEP. And so impact on HIV, you can see the blue and orange lines are the lowest here. So the CAB-LA reduced the incidence more, averted more infections, averted more AIDS deaths. Then they looked at the impact of the cost on HIV programs. And despite the fact that the total number on treatment was reduced with CAB-LA, the total cost of the program actually increased with CAB-LA. And this has to do with the cost of CAB-LA, and this looks at the cost effectiveness over 12 years. And actually, at the present cost, oral PrEP is actually more cost effective than CAB-LA. And they looked at what would be the cost of CAB-LA in order to make it as cost effective as oral PrEP, and found the acceptable range of cost to be $9 to $15 per injection. So while CAB-LA is highly effective in preventing HIV transmission, the cost of the drug actually needs to be significantly lower for it to be cost effective in South Africa. And just to note, the cost in the US is $3,700 per injection, which is clearly unaffordable for low and middle income countries. Shirley, quickly for you.
Thanks, Lynn. Thanks for sharing this evidence with us. So when it comes to PrEP as an essential component of the combination prevention strategies, new models for PrEP show promise. 6-monthly prescriptions and HIV self-testing reduce the need for clinic visits, and adaptive strategies to improve adherence, example, PrEP plus the SMS work, but don't always overcome structural barriers, as Lynn pointed out. And then long-acting cabotegravir for PrEP, it's coming and has good promise there, but again, the cost is a challenge, and it would have to be greater than 200-fold cheaper than current price in order to make it available for people. And then again, as Lynn pointed out, just the cost difference between $9 to $15 against $3,700 USD. Yeah, back to you, Lynn. Thank you.
Okay. Moving on to talk about adolescents and HIV. This study looked at the impact of intimate partner violence, looked at over 1,000 adolescents in the Eastern Cape that were interviewed yearly for 3 years, and they collected health data. So they found that 37% had a lifetime exposure to IPV or sexual abuse, 23% of females, 5% of females reported both lifetime IPV and sexual abuse, 11% in the past 2 years. This shows you the impact of sexual violence on ART adherence. And you can see with both IPV and sexual abuse, ART adherence goes down to 38%. Multivariate associations between IPV sexual abuse and past week ART adherence were significant. So they concluded you need to ask about IPV and sexual violence, make referrals when possible, and scale up prevention programs and response services. This looked at a behavior-based intervention on improving male attitudes towards women. So it's called the No Means No curriculum, which was implemented in South Africa. They trained male programs facilitators to conduct an 8-hour curriculum for adolescent boys and young men in 4 sub-districts. And you can see what the focus was and the model was here. They then conducted pre and post questionnaires to evaluate the effect on attitudes towards women and gender-based violence, and found significant gains in knowledge and improvements in attitudes and knowledge with those who participated in the curriculum. So they concluded this 4-week training program was effective in improving attitudes towards women and successful intervention if seeing gender-based violence. This is from the SEARCH cohort. It was a randomized trial of adolescents in clinics in Kenya and Uganda, and it looked at a multi-level intervention, including life stage assessments at visits. Choice of clinic access was important. They offered choice and time of access. Rapid viral load feedback with use of point of care. And also they had a provider collaborative that allowed people to talk to each other about hard cases. So this looks at intervention, utilization, and facilities. So they offered off-site appointments, appointments by phone, off hours, and off-site. And you can see that the adolescents took these alternative clinic visits as selected as their choice by many participants. This looks at life stage assessments during the study. So 85% had 4 or more life stage assessments. And viral load delivery, the mean time to getting the result was 38 hours. 80% of results delivered within 72 hours. So the intervention was implemented well. And here's what happened in terms of viral suppression. So in orange is the control, in blue is the intervention. And you can see at baseline, they were very similar in terms of viral suppression, but there was a 15% increase in suppression in the intervention group, with 88% suppression in the intervention, 80% in the control. They then looked at this by whether the child was engaged in care or recently engaged in care or re-engaging in care to see whether there was a difference. And they found improvements with the intervention across all of these subgroups defined by baseline care status. And particularly impressive was the impact of the intervention in those who were re-engaging in care, where suppression was 85% with the intervention versus 53% with the control. This shows you that the intervention worked both in women and men and older and younger adolescents. Most of the participants switched to dolutegravir. Switching was the same in both control and intervention, but despite the switching being the same, the intervention was associated with a higher probability of suppression. So in those who did switch to dolutegravir, it was 92% with the intervention versus 88% with the control. So it increased viral suppression compared to standard of care overall in key subgroups and during dolutegravir transition. Shirley. Hello.
Thanks, Lynn. Yeah, thank you, Lynn. Yeah, so just from what we see, again, counseling for gender-based violence should be part of adherence for ART adherence for adolescents, and IPV and sexual abuse strongly associated with poor adherence, and interventions targeting adolescent boys and young men can help to reduce GBV. This is something that we really need to see how within our programming to engage not only our girls, but both the boys and the young men in our interventions. And the key message here is also there's an urgent need to link violence prevention and adolescents HIV services. And effective sexual violence prevention and post-violence care are essential in supporting adolescent ART adherence and cross-sectoral interventions. And how do we engage both within the community, the schools, as well as the parenting programs? And on the adherence strategies must be multi-layered. Phone support and community delivery of ARVs improved adherence for adolescents and young people. Back to you, Lynne. Thank you.
Okay. One quick one on DSD initiation. This asked, how soon should eligibility for DSD happen? Usually you have to have more than 6 months on treatment before you can go into DSD. So in Zambia, they did an electronic medical review, and they looked at those who enrolled in DSD early, DSD with less than 6 months of treatment, with 45% having only 0 to 3 months of treatment. Established enrollers, the usual, they found no difference in age, sex, or setting. And this just shows you the distribution of time on treatment. And they looked at the rate of loss to follow-up at 18 months. And across most DSD models and all ART dispensing intervals, early enrollers, which is shown in blue, had similar or lower rates of loss to follow-up at 18 months after treatment initiation than established enrollers in orange. And this looked at the adjusted relative risk of a loss to follow-up at 18 months. So early enrollers had a risk of loss to follow-up that was actually lower than established patients for most models of care. There was a potential bias here that people who enter early may be people who have better adherence, but despite this, it does say that DSD models do work for some early treatment patients, suggesting that a blanket exclusion of those on treatment for less than 6 months should be reconsidered. And ending up talking just briefly about COVID. This looked at the incidence of SARS-CoV-2 infection in children in Europe in the EPIC study. 11 cohorts with 1,700 children with HIV from 9 countries. 8% had been diagnosed with SARS-CoV-2. The majority of these kids were on treatment. Only 39 had additional clinical description available. 61% had symptoms, all were mild. 8% hospitalized, no deaths. So the incidence of SARS-CoV-2 was relatively low and generally mild in children with HIV, as seen in children without HIV. Slightly more common in older children and in those who are not virally suppressed, and that's in the box up here. And then there was the WHO Global Clinical Platform for COVID-19 assess the risk of severe and fatal COVID in people with HIV. So it's a global platform where countries report in with people with HIV status and COVID. So 8.2% of the patients in the platform were living with HIV. Symptoms were similar to HIV negative, except less frequent cough. Persons living with HIV had more frequent underlying conditions. And importantly, people with HIV had a higher risk of in-hospital mortality compared to HIV negative people, even when adjusted for age, gender, and comorbidities, with people with a high viral load and low CD4 having the highest risk. And this just shows you risk factors for in-hospital mortality in patients with HIV. Age, CD4, viral load, comorbidities. So the risk of in-hospital mortality was 52% higher than in HIV negative, even when adjusting for multiple things. And independent mortality risk factors were older age, chronic kidney disease, diabetes, hypertension, and viral load and CD4 less than 200. They did see a decrease in mortality in HIV positive and negative individuals with the Omicron era, but the decrease was less in HIV positive individuals than HIV negative individuals. And this is, I think, the last one, which looked at the use of outreach mobile clinics in maintaining linkage to services in Malawi. So Malawi used mobile health clinics to maintain HIV services during COVID. And you can see here over time, new HIV positive diagnosed, HIV negative, and HIV self-testing. So there was a 37% decrease in HIV testing from the 21 months pre-COVID to the 21 months post-COVID, but they managed to maintain this with using HIV self-testing. This shows you the mobile clinics and the services that they provided. And this shows you that the average monthly visit per clinic in the pre-COVID period here and the post-COVID period. And using these mobile clinics, they were actually able to maintain an average monthly visit. This looks at testing and HIV positivity per month. And found that post-COVID tests in the clinic increased by 22%, mean positivity rate 2.8%, compared to the national average of 2.3%, compared to pre-COVID tests where the mean positivity rate was 3.6%. So community-based care effectively blunted the impact of COVID-19 in rural and remote populations. And they felt that lessons learned include provide services where the people are, be flexible, you need to build community trust, and have a partnership with the local ministries. Last one was impact of COVID-19 on young people. So this was a quantitative and qualitative study of HIV positive young people, a mobile web survey and focus group discussions, asking them what happened with their life. So they found that there was an increased need for STI and HIV testing and/or treatment services during the COVID pandemic. For example, 10% of HIV positive youth said that they lacked access to treatment. Underlying reasons for difficulty in accessing services included fear of COVID-19, lack of transport, the facility was closed, a curfew due to lockdown, and stock out of medications. Qualitatively, there was an inability for support groups to meet, medication was put on hold, inability to get viral load testing, and an increased vulnerability of all groups of young people. So the recommendations from young people was that HIV prevention care and treatment services should be available even in a pandemic. Mental health needs to be important, combat stigma, address stockouts, distribution and adherence issues, ensure access to PrEP, integrate sexuality education into online learning, which was lost with online learning, and provide economic support for young people, including those with HIV. And I think, Shafiq, it's now to you.
Lynn, thank you very much indeed, and good morning, good afternoon, everybody. Shafiq Isaji joining you from New York. And Lynn has given us a wonderful overview of a lot of the research that was presented at the IAC. I'd like to shift gears slightly and just present a couple of slides on the Global Alliance to End AIDS in Children by 2030. Which was actually also launched at the International AIDS Conference. This is a new global initiative to accelerate evidence-based action at scale in order to help countries achieve an end to AIDS in children by 2030. Next slide, Lynn.
Second. There you go. Sorry.
Thank you. This is, of course, to those of you who perhaps are less familiar with this, the successor to the global plan and the 3 frees. But unlike those 5-year initiatives, we see this as a 9-year strategic initiative that will take us to the end of 2030 and that will roll out in 3 3-year-long phases with the ultimate goal of ending AIDS in children by 2030. There are 4 pillars that constitute the work within the Alliance. The first is essentially ensuring high quality care and treatment for children and adolescents living with HIV, as well as HEUs, perinatally exposed children who are uninfected. The second pillar is closing the treatment gap and optimizing retention and continuity of treatment for pregnant and breastfeeding women living with HIV. The third is preventing new infections among pregnant and breastfeeding women, especially among adolescent girls, of course, who are HIV negative at first ANC, but may acquire HIV during pregnancy or breastfeeding. And in many regions, that is now a major driver of new infections among children. And the fourth cross-cutting pillar is addressing the rights, gender equality, and some of the social and structural barriers that hinder access. And these four pillars translate to four populations of focus: children living with HIV, adolescents living with HIV, the HEU or perinatally exposed children, pregnant and breastfeeding girls and women who are living with HIV, and those who are HIV negative but potentially at risk of acquiring HIV. Next slide, Lynn. I'm not going to go through this in detail, but we obviously did before launching this alliance, we did a deep dive into what we learned from the global plan as well as the 3 frees. And so we've tried to incorporate some of those lessons into the principles that are informing the global alliance. And I just want to highlight a couple of things. The first is this longer time frame, and I think that's important because, you know, in the past, we've sort of had these shorter initiatives that have been more or less successful. And then when the initiatives end, we sort of say, well, we didn't reach our goal, but now let's try this and regroup and see if we can get there. So this says, okay, no more short-term initiatives. We have our goal of 2030, which is consistent with the SDGs and the SDG 3.3 in particular, which is about ending AIDS. So let's take that time frame and let's focus our energies and attention to achieving that objective in the next 9 years. And then the second key point is that we really want this to be a more bottom-up approach. And so we're promoting country leadership and community ownership. And I think you'll see in the next couple of slides that we're really putting a focus on those two aspects of the work going forwards in the alliance that draw from the good experiences from the global plan and the 3 frees. And the third point that I want to underscore is that we don't just want to look at programming gaps. That's of course important and continues to be important, but we also want to focus a little bit on some of the structural barriers that have hampered progress, especially among the more marginalized communities where access to services is still lacking. Next slide, Lynn. So we had a very successful launch at the AIDS conference in Montreal. And this is just an example of some of the publicity that the launch generated. At that launch, we had several of the phase 1 partner countries that have been invited and accepted the invitation to join the alliance. And these include Angola, Cameroon, Cote d'Ivoire, DRC, Kenya, Mozambique, Nigeria, South Africa, Tanzania, Uganda, Zambia, and Zimbabwe. And importantly, although we reached out to these countries, we didn't ask these countries, we didn't tell these countries they were prioritized and part of the alliance. Instead, we invited them to partner with us, to share their learning, and to join the alliance to bring that learning into a framework that can allow all countries to accelerate their progress. And I'm happy to report that all of those 12 countries that we reached out to have now formally accepted the invitation. And we're looking forward to the next sort of kickoff of the alliance in Africa, which has been planned in the first week of November in Abuja, where we will gather, you know, some high-level participants, ministers, as well as alliance partners, communities, and other stakeholders to really take a bit of a deeper dive into what programming could look like in the phase 1 partner countries. And the next slide, Lynn. And so just to note that over the 3 phases of the Alliance, we will have an opportunity to kind of take stock at the end of each 3-year period, understand what's been working, what hasn't been working, shift our focus both programmatically as well as geographically, so that by the end of the 3 phases of the Alliance, we will hopefully have a truly equitable approach, one that doesn't just focus on the high burden countries, but also addresses some of the challenges and issues that are important for children in lower prevalence, more concentrated epidemics, to ensure that those kids are not left behind in our global response. And so for more information on the Alliance, some of the documents that have been developed to date, as well as finding out how you could join the Alliance. The membership is open to countries, of course, but also to institutions, community-based organizations, civil society partners, and other stakeholders. So please feel free to visit that website, and please do reach out to myself and other colleagues if you have questions about the Alliance. Lynn, I think that's my last slide, so I'm handing it back over to you.
Okay, so question and answer. I'm sure people are completely exhausted, but the slides will be made available to you so that you can look at them in more detail, and we'll just open for questions now.
Great. Let me moderate this part of the conversation, Lynn. There are already some questions that have come in on the chat, so I'll just go through some of those. And other panelists, please feel free to answer these questions as well. The first question is, how much of the decline in progress that we've seen in recent years can be attributed to the impact of COVID on service delivery between 2020 and 2021? Lynn, what are your perspectives on that?
Yeah, I think I actually hope that that's the case, because otherwise it's even more discouraging than it currently is. But certainly I think that there has been impact. There's been some studies that, you know, show plus minus in terms of its impact on the PMTCT cascade. And certainly people have developed innovative ways to deal with it that hopefully will then bring these numbers back up. But you know, this stagnation occurred prior to COVID. So, you know, some of the decrease may be due to COVID, but I think still we have to say that we're not doing the job we need to do to be able to get to elimination.
Thank you for that, Lynn. Another question from Nobubelo from the South African MRC. Thank you for this question, Nobubelo. She notes that Botswana has achieved the 95-95-95 targets. Do we know whether the third 95 has also been achieved in younger populations, specifically kids under the age of 5? And if so, are there any lessons from Botswana that we can adapt to be able to support other countries that want to achieve this? Lynn, I don't know if you are able to answer that. If not, perhaps Laurie could also chime in on what we know about Botswana's 95-95-95 targets as they apply to children.
Yeah, I think Laurie would probably know better than I.
Thanks, Lynn. Thanks, Shafiq, and thanks for the question. I don't know in terms of the viral suppression coverage. We do know that in terms of the second bar, the treatment bar, kids are quite far behind in Botswana, according to the estimates. The last estimate for 2021 for 0 to 14 years was 69% treatment coverage. Whether there's someone on the call who knows sort of the laboratory results for kids who are in the system and on treatment, that would be great. I don't have that information at hand. Thanks.
Wonderful. Colleagues on the call, if anybody has an answer to Nobubelo's question, please feel free to type in the chat so that all of us can learn from that experience. Now, there's a couple of questions in the Q&A. Please keep these coming, colleagues. They're very interesting questions. Lynne, the first is for you. Would it be reasonable, this is from Ruslan at UNICEF, would it be reasonable to assume that the low rates of viral load testing access is associated with poor service delivery and potentially therefore with lower rates of viral suppression compared to models with good service delivery where access to viral load dolutegravir and adherence support is available? So it's not access to viral load testing, but the service delivery model that has impact on viral suppression. I think that's perhaps more of a comment, but I don't know if you have any thoughts on that.
Well, I think that's true, but none of the studies have really been able, they haven't really differentiated it in the way that you have discussed. So it would be interesting to look at other pieces of the programs and viral load suppression. You know, the studies that I were reporting on, you know, that they showed, you know, here's viral load testing, here's viral suppression. They haven't looked at the program as a whole. But you know, I think generally that's probably a reasonable point. Yeah.
Fantastic. There's a question from Subha Raghavan asking about India and why India is not part of the Global Alliance. Subha, that's a great question. And actually, India was very much on our minds when we were thinking about how to frame the bottom-up approach of the Global Alliance. I think, as you all know, during the global plan, where we took a different approach, it was more top-down, and we prioritized countries and said, you are priorities for the global plan. And I think there was a lot of pushback from countries, and some countries, India in particular, never really bought in to the global plan. So I think what we're trying to do this time is to say, you know, we have the alliance, it's open enrollment, if you will, and we are certainly open to all other countries that wish to join the alliance, but we don't want to force it down anybody's throats. Rather, we are hoping to show that the alliance is effective, productive, and can make change happen, so that countries come to us and say, we would like to join the alliance as well. They're very, very welcome to. Indeed, we've learned just this past week that a couple of other countries in Southeast Asia may be interested in joining, Indonesia, for example, and we're extremely welcoming of that. We haven't chosen the priority countries. We have invited them to partner with us, and in that spirit, certainly other countries would be very welcome to join the alliance. So I think it's an open question, Subha, and we would be very welcome to seeing other countries, including India, submit interest in joining the alliance. Now, Eleanor Magongo from Uganda has a question which is sort of an inverse of the first question on the impact of COVID on service delivery for HIV. But she's asking how countries and HIV programs have recovered from the HIV epidemic. What do we know about the ways in which those countries have actually recovered their services, and what are some of the key learnings that we could use to implement in HIV programs elsewhere? And again, I think, Lynne, this is a question directed to you, but certainly if there are others on the panel, including Laurie, Ulrike, who wish to respond to this, then please do go ahead. Lynne.
So at this meeting, I didn't see any presentations that looked at, you know, services pre-COVID, COVID, and currently. So I can't really address that. There were presentations last year that suggested some recovery is happening. And I think certainly that there are a number of pieces that learnings from COVID that will be helpful in the future. And I think that really has to do like with differentiated service delivery and multi-month dispensing, which kids were not included in initially. It was primarily targeted to adults, but there was a presentation last year that showed a dramatic increase in multi-month dispensing for children, differentiated service delivery for children. And hopefully that lesson that has been learned that we need to be able to do that for kids. So I do think there are things that we did to adapt to COVID that should be staying in place once COVID is over. And
Great.
Is COVID over? I don't know. It's
COVID over. Not yet, and certainly if COVID isn't over, then there will be others that will come along. Shameless plug here, we at UNICEF are launching a podcast that will look at the sort of future for health services and HIV services reimagined in a post-COVID world. And we will be launching that podcast before the end of the year. So those of you on our community of practice, do join when that podcast is available. We would be delighted to see many of you tuning in and listening to some of our interviewees to talk about exactly some of this best practice and learning from COVID. So another question from Zorema Neto. I think this is for me. What were the criteria for choosing the countries involved in the Global Alliance? Zorema, we looked at the epidemiological data, and we tried to ask ourselves the question, which are the countries that we really think we would like to see partnering with us within the Alliance, based on their unmet need and the opportunity really to share experience and learn from each other. And that's really why we reached out to those particular 12 countries. And I just want to explain that in the process of doing this, we actually had initially identified 10 countries, but then we got input from 2 other countries saying, we've heard about this, we'd like to join. So we extended the invitation to those countries as well, and now we have 12. And I think in the spirit of being, bottom up and led by countries, as I said, although we did this exercise, this epidemiological exercise where we defined some criteria to try to identify where there was the greatest unmet need, we were very pleased when additional countries, and it was specifically Cameroon and Cote d'Ivoire, wanted to be part of the Alliance and to learn from the Alliance and share in our experiences, and just be within the global dialogue that we're hoping to create with the Alliance. We were very pleased when those additional countries wanted to join, and we would continue to welcome others. And Zorema, if you have further questions on this, please do reach out to me. I'm going to pop my email in the chat so that you can connect with me if you wish. Second question from Carmela Abate. Would you like to comment on the countries which have wider use of real-time point-of-care testing to those in which samples need to be transported, thereby delaying mothers and children getting their results immediately, and the effect that that has on pediatric outcomes? Lynne, I don't know if you had a specific study and abstract that you presented that spoke to this, but do you have any comments on the question that Carmela is asking?
Yeah, I think it's a great research question. I think we know with point of care early infant diagnosis that there are some real advantages that have been shown. There was a paper in Lancet. There are a number of other papers showing that more rapid return of results back to the mother with point of care, and then more rapid putting the kids on treatment. We don't have more longer term follow-up yet, but that does seem to be advantageous. One might think that you would see similar things for viral load, but I don't know that there's been any research done. So good research question.
Yeah, I wanted to underscore that the data that you did present showing treatment outcomes in children treated as early as 3 months, even that showed that we still have high mortality, and that mortality is occurring within the first 6 months. So it just underscores the importance of getting kids that are infected started on treatment as early as possible. And obviously a testing strategy that gives you the results more quickly allows you to act more quickly to initiate those kids. So I think the effect on pediatric outcomes, if you can get that chain of events to work properly, would certainly be greater where you had a point of care immediate test result as opposed to waiting for weeks, sometimes months before you get the result available. But thank you for that question, Carmela. And the next question from Mayowa Tiam, that's the last question for now, but please do keep them coming in. Thank you, Lynn, for the great presentation. It is still challenging to get men to test for HIV, and even more so to screen for syphilis. In your opinion, what are the measures that we could take, leveraging the dual elimination platform, to increase uptake of dual HIV syphilis testing among men? You know, could we use some of this work that we're doing for women for prevention of mother-to-child transmission of HIV and syphilis and learn from the HIV epidemic and say, no, we should think about men upfront rather than realizing downstream, oh, men don't seem to test as much. What could we do now to improve the way in which men get tested?
Yeah, I think it's a very good question. And is there a reason why that we would not do dual testing at all points of HIV testing? I mean, you know, it doesn't have to just be A and C. Anywhere where HIV testing is being done, one could incorporate HIV syphilis testing. So I think that is really what I would see is, you know, view this as the way to do HIV testing in the future. You do both HIV and syphilis.
Fantastic, Lynn. Thank you very much for that perspective. Colleagues, we are, this has been a longer than usual webinar because we just had so much that we wanted to get through and to communicate to you. We have a few more minutes available for questions, so please do type in additional questions if you have them. I see that Rike has provided you with my contact information, so please do reach out for more information on the Global Alliance if you need to, and also sign up on our listserv to get updates on our webinars, other publications on children and AIDS, as well as the podcast that I mentioned. And with that, Rike, let me turn back over to you to close us out. Thank you.
Thank you, Shafiq, and thanks to Lynn, Laurie, Shirley, and you for this excellent webinar, the excellent presentations and attention to the question asked by everyone. Before we close out, I just want to mention that if you want to learn more about the updates and outcomes from the HIV Pediatrics workshop, Virology Education has created an on-demand e-learning course that is named Meeting Highlights of the HIV in Pediatrics 2022 workshop. So I'll post a link in the chat box, but the registration fee is waived for academia. So for any healthcare professionals, NGO representatives, researchers, and students, you can register for free, and it will start October 1st. So go check that out. And then, as usual, we will post a recording of the webinar on childrenaids.org, where we will also make available both the slide deck used for the webinar, as well as an extended slide deck covering a broader range of studies that are presented at the two congresses. So thanks again, everyone, for joining. It's been a wonderful webinar, and we hope to see you again at the next one.
Thanks, everybody. Bye-bye.